Let's see. I'm going to go a little bit rapidly so that we don't shortchange our last speaker. We're going to talk about common variable immune deficiency at this point in time. I'm an internist, but I have the good fortune to be able to see children as well at Mount Sinai. I have a double appointment, which is very lucky for me. For those of you who are internists, I have to give a big cheer because I think more and more people are immune deficient who are adults, and most of the people who are immune deficient are in fact going to be over the age of 21. And because of that, I think adults get shortchanged. So first of all, just CVID, this is a laboratory definition as far as I'm concerned. This is the IUIS nomenclature as well, which is that we have a stipulation of age, partly because when you tell a person that they have CVID, it tends to turn your brain off, and that tends to make people think they've solved the problem. And so if you stipulate a little bit older, then that gives plenty of chance to be thinking about other genetic diseases that might be present in the young age group. In my view, and in the view of Helen Chappell, and we've put together a number of reports on this topic, and you'll see this published in various places, the immunoglobulin levels are generally pretty low, oftentimes much lower than the number that's noted here, and usually the IgA and or the IgM. Two isotypes are down. Lack of antibody, it has to be proven. You have to do immunizations and you test titers, and you have to be sure about that, and then you go back and you think again, and you think, what did I miss? And look for other things, and once you've done that, then this rather generic name gets popped on to the chart. And it almost never leaves, and so we try really hard to be sure that that's about as accurate as we can possibly be at this time. And of course, it's a group of genetic defects, most likely, and some of them, there are going to be some surprises that we did not anticipate could even look this way. In terms of the gastrointestinal disease in CVID, we have a number of things to think about. First of all is infections. Of course, that comes to mind immediately. But then remember, there's various functional issues which anyone can have. There can be food intolerances. There could be, for example, celiac disease or lactose intolerance, perhaps. There may be frank autoimmunity, or there may be inflammatory conditions that we understand very poorly, and I'm going to talk about that a little bit more because I think that's where so much of our anxiety occurs amongst the patients who have so much difficulty, and we really don't have a very good clue about mechanisms. Bacterial overgrowth is a problem, especially for those who have a certain amount of inflammatory disease. And then, of course, there's their unclear mechanisms that we really have no clue, and certainly we need a lot more information. I don't think most of the group here is terribly familiar with the USID-Net. This is a United States Immune Deficiency Network, which is a registry of patients with immune deficiency. And this currently is supported by the NIH, and it's a program run by the Immune Deficiency Foundation. But if you take a look and you say, well, what are the problems? Out of 1,472 patients with CVID, about 62% of them have some form of immune deficiency, some form of gastrointestinal difficulty. And if you start at the top, you can see, well, gosh, we're collecting a lot of micro data here, which is wonderful. But as you can see, many people will complain of gastrointestinal reflux or chronic diarrhea or intermittent diarrhea, abdominal pain. You can see quite a few things come up on this list. So I just point that out to say, first of all, that the registry collects quite a bit of very, very useful data. But as you can see, a lot of these things are found in people who actually are not immune deficient. So that's fortunate and good to know, because not everything that you have, if you have CVID, is due to that immunological diagnosis. Plenty of other things can occur as well. So I just put that slide up to brag a little bit about the USID-Net registry, because the data is getting to be quite wonderful. In terms of infections, I think everyone here could have named these as well, which would be H. pylori, Giardia, Salmonella. I don't say these are exactly in order, but these are the ones that we commonly understand. Cryptosporidia was actually first found, not in HIV, but it was first found in immune-deficient patient, hypogammaglobulinemia. CMV, norovirus, is increasingly becoming something that we're quite aware about and gives us an interesting additional clue as well. And then, of course, bacterial overgrowth, which means just normal bacteria, but there's just far too much of those types of bacteria. I'm going to say one thing about celiac disease. I don't know about Europe or the rest of the world, but the United States seems to have a fad about gluten intolerance right now. Is that True elsewhere? Ah, yes, well, it's sweeping the world. So how common is it? And you might like to know, because one of the first patients that I saw from Italy who was thought to be wheat intolerant was actually looking like the most malnourished individual I'd ever seen, because she was on a wheat-free diet and she had lost a great deal of weight. So you might like to know, well, is it common? Well, I thought this article was very nice, and this is from the German group. 20 of 250 CVID patients had clinical phenotypes resembling celiac disease, and 4 of those carried the celiac-associated histocompatibility marker, while all of the celiac-positive patients in their patient cohort carried that marker. A gluten-free diet was then applied to 2 out of the 4 patients with that high-risk allele, and they ended up having some benefit in 1 or so of those. So if you say that out of 250 patients, 20 of them had something they thought was wheat intolerance. In fact, only 1 of them really turned out to be that way, and most of them didn't carry the marker in any case. And so for us, we use that genetic marker, and we don't really think wheat intolerance is a very common problem. And in terms of the USID-NET registry, celiac disease is only 2%. So I generally don't think wheat withdrawal is actually worth very much in CVID. Somebody here may correct me and come up with a few patients that have greatly benefited, but I think it's not a common proposition. Now, this is the thing where we spend so much time, and I have to tell you, I took a slide out because I thought it was too disturbing, which is that the mortality of patients who have these non-infectious complications is rather striking. And it's disheartening, as a matter of fact, because it tells you how far we have to go with the inflammatory complications of CVID. We really have not got a good fix on it. And this is a combination of Dr. Chappell, who first pointed this out in a wonderful article in Blood in 2008, and then she and I put some more data together. This is the British Journal of Hematology, and tells you something about how the system goes. In CVID, somewhere about 25 to 50% of patients just have infections. That's all they ever have. They're fine. You have actually a hard time getting them to come back to you for an appointment to renew their gamma globulin. They're fine. They're perfect. The other group, 50% or so, and of course these are concentrated at medical centers, have a lot of difficulty with the inflammatory complications. And so what are they? As you can see on this particular slide, those who had nothing particularly were this little group up here, which is that green block, which is the no complications section over here. But in terms of the other complications, you can see them listed out: granulomatous disease, lymphoid malignancy, which, by the way, only runs about 3%, so I don't think it's something that we have to get terribly excited about right now. I mean, it's true, but let's not go overboard with the lymphoid malignancy, hepatomegaly, cancer, and so forth. The one I want to point out is that yellow little block, that's the enteropathy block, and that's the one we want to talk about now. So enteropathy runs about 8%, and that's probably a little bit higher than normal, but that's about where the numbers usually go. If you'd like to compare that to Dr. Chappell's article of 2008, different centers reported different numbers. For example, the Czechoslovakian group was a little higher than the Swedish group here, and that correlates very well with Ben Gaithman's recent compilation of CVID as well. Enteropathy ran about 9%. So I thought you might like to just see how those numbers stack up. Pretty much everyone agrees there is a component, and we all see pretty much the same numbers, regardless of where we happen to be dwelling. Now at Mount Sinai, I've collected somewhere just short of 500 patients with CVID, and I followed many of these patients and collected their medical records, starting at Sloan Kettering and then more recently to Mount Sinai Medical Center, where I've been for about 3 decades. And it turns out that about 52% have these non-infectious complications. And of my patient group is a little higher at about 12%. I'd like to point one thing out, which is that Mount Sinai is the inventor of Crohn's disease. Brill Crohn was at Mount Sinai, and so we are very Crohn-centric. So it could be that I see more Crohn's disease than others do because our gastroenterologists think about it quite a bit. So I might be a little bit Crohn-rich. Let's put it that way. So in terms of what do our patients have? Well, if you say these are the patients who have the gastrointestinal problems, there's 55 of those patients that I've seen. That's about 12.1%. And this is what it looks like with enteropathy, chronic diarrhea, inflammatory bowel disease, which, and our physicians are very picky about what they call Crohn's disease, malabsorption in a certain percent, need for parenteral nutrition. Known infections can also occur in these subjects, nodular regenerative hyperplasia in some, and then there's quite a few things that are also occurring in that patient group. So this is kind of the general overall picture of these patients. And of those, they are about equally split between males and females. The average age of diagnosis, as for most reports that you is in the middle of the 30s. The immunoglobulin levels are listed here. A good number of these patients also have autoimmune disease. 19% died. And this is the slide I took out. The mortality in the patients who have GI disease or malabsorption, especially malabsorption, is probably one of the worst clinical phenotypes, I would say. I took the slide out because I just didn't like the way it looked, but it is true. It's a very, very serious parameter. Average age of death was 44. Mean age from diagnosis CVID to death was 11 years. Most of the patients come in with this phenotype. And 3 patients had additional cancers and tumors as well. So it's a complicated medical group. It's not a simple patient group. They have autoimmunity and they have other diseases. I thought you might like to see the French cohort. So thank you very much for compiling the data from the French group as well, which came out 2010, and I'm sure there's a lot more to say now, which is, as you can see, it's a complicated group. These patients have a lot of other things. A lot of other immune dysregulation parameters are also occurring. Mean age was very similar to the one that I quoted for you. The male-female ratio, very similar. Many of them had bad diarrhea, abdominal pain, dyspepsia, very slender, malabsorption, and then a lot of autoimmunity, and then quite a few lymphocyte abnormalities are present in that patient group as well. So the CVID cohort that has enteropathy is a complicated group, and there's something that we don't understand about that. I will show you some slides. This is a man who had lost somewhere around 90 pounds, and you can see why. He has no absorptive surface. It's been invaded by these, I guess, nodules. These nodules contain B and T cells. Predominantly, they are nodular hyperplasia. If I saw this patient again now, I'm sure I would probably give them rituximab to probably wipe out some of those excess non-functioning, very useless B cells. The same as over here. Lymphocytic infiltrate. I don't know how you know what the GI tract is supposed to look like, but it's supposed to look like a little bit of a shag rug with little villi predominant, and as you can see, the villi here are distorted, and here they're very blunted, like they've been sawed off with a little saw. And then all these little marks here are lymphocytic infiltrate. Not, again, what you're supposed to be seeing in a patient with a normal GI tract. And then the other, I always look at this slide, and I think it's interesting from a lot of points of view. One is there's no plasma cells. Well, you've heard before that the end result of B cell development producing a plasma cell is exactly what characterizes best CVID, loss of plasma cells. And the GI tract just explains this and illustrates this so completely, predominantly. And the reason why I think it's amusing is that I've had probably like 4 or 5 referrals, and once every while another one will appear, where a gastroenterologist calls me and says, oh, it's so funny, I have a patient who has got this terrible diarrhea, and we did a biopsy, and gosh, there's no plasma cells. And I'm thinking, well, you know, did you measure immunoglobulins? Well, actually, no. So I'm thinking, well, you know, somehow maybe they could have used a GI biopsy second, you know, rather than immunoglobulin level first. So I always think it's very kind of interesting to get your diagnosis sort of in a backwards way like that. So what else can you see in the GI tract? Well, you can see a neutrophilic predominance here, in this case, with this crypt distortion here. And then here, on occasion, but not very commonly, you will see gastrointestinal granuloma, which have embedded themselves into the mucosa as well. In terms of staining, Fabricio Suto has made some wonderful slides for me at various times. T cells invade the GI tract. They're supposedly to be not present in such huge numbers. All those brown spots are CD3 T cells. They may be helper, they may be suppressor. In this case, this one was a little bit more in terms of some patches of CD4 T cells. CD8 T cells are perhaps a little bit more predominant, but B cells are not particularly common in the GI tract in the CVID patient population. So your first thought would be, this is more of a T cell infiltrative disease. But that's probably not the only story, and I'll come back to that in a moment. You can also have frank autoimmune enteropathy. In other words, not only can your immune system make an antibody to your platelets and your red cells, but it's possible to make an antibody to your enterocytes. So we don't actually have, I don't have access to a wonderful test for this. Perhaps it's a little more common than I know, but the characteristic features are loss of goblet cells, Paneth cells, and some of the other characteristics of the gastrointestinal tract. So you can make really an autoantibody against your GI tract. This report has set everybody back on their heels, which is that chronic norovirus infection in CVID was reported from the Cambridge group. And in this case, 8 patients in the CVID cohort with rather severe enteropathy showed persistent excretion of norovirus. And then analysis of some of their archived biopsy tissues showed the same thing with villus atrophy and so forth. And it also showed that sequencing from some of the previously harvested tissues showed that some individuals had carried those same strains for a very long period of time. And then characteristically, patients without enteropathy did not have norovirus. And as you probably read this report, ribavirin created a very, very, very good benefit for this patient, for the patients that have been treated. So this is just a picture straight out of that paper, which is pretty impressive, which is that some of the pathology that I showed you, and I was telling you that that's non-infectious enteropathy as far as we've been concerned, now turns out to be, well, we just didn't know what the bug was. And so now let's think about infections a little bit more seriously. And as you can see, the architecture then became restored after this antiviral therapy. So it puts you back and you think, well, what did we just hear? We heard the bacteria now from from Hong Kong, Dr. Lau. Dr. Lau, who's expressing the fact that we don't know the bacteria. It could even be a fungi, and we've just never looked for fungi here. Could it be a fungi? Could it be something else that we use massive amounts of antibiotics? Perhaps we're making an ecological disaster in the GI tract. It's very possible. And so I think we need to take a step back and say, you know, what are the other bacteria that are present here? In terms of norovirus myself, my own experience is limited to 1. So despite all the fact that I've seen all these patients, I've only seen this once. Does that mean that my assay isn't good? I don't know. I can't tell you. But believe me, we are very much trying to discover how much we may have missed, and so far we don't know. But I think all of us are going to pay a lot more attention to the microbiology. Now this is a management session. I think we're supposed to talk about management a little bit. So what do? We have a patient who has this problem, and we know it's very serious and we need to get a handle on it. So what do we do first? Well, we're extremely serious about parenteral nutrition, water-soluble vitamins, vitamin K. Most of our patients have been on antibiotics for so long, their pro time is slightly long because their vitamin K is depleted. Pay good attention to that. Zinc is absolutely essential for the healing of the gastrointestinal tract, so you must be absolutely certain zinc levels are normal. Calcium, especially for the ladies. Osteoporosis is fairly rampant in CVID, especially amongst the females, and you have to be sure to replace the calcium, the vitamin D, as much as you can. Diet changes, lactose elimination most likely. I said wheat probably wasn't that important. Cholestyramine is just something which binds various fatty, I guess it's mostly a bile acid absorber, but it also strips out your vitamins, but it's a way of creating a sort of an artificial bulk agent in the GI tract, and many of the gastroenterologists use that. Could it be a way to, for long term, probably not, but for short term, perhaps. And of course, antibiotics we use, first of all, even if we haven't proved a bacteria, we generally will try antibiotics, generally metronidazole first, and rifaximin or other non-absorbable antibiotic, and consideration of antivirals. And so this is where we usually start. Over here in terms of useful, all of these are useful. What about other things? Well, now then we get into the things that we don't like to do, which is immunosuppressants. None of us are happy with this prospect, but you have a patient who has something quite serious, and let's try to figure out what we can do. So the first thing is oral steroids. Generally speaking, it works, but you can't taper, and so that's a problem. And so we generally rely quite a bit on oral budesonide. We take a page right out of the Crohn's disease book, and we'll use up to 9 milligrams a day. Don't forget mesalamine, for example, might be another one that you can use, and we've used that quite a bit. The third option, down perhaps in preference of list, is azathioprine or 6-MP. Again, taking a page right out of the Crohn's disease book. Is it helpful? Yes. Do you worry about it? Yes. So that's something where we are never sure that we're on the right track, but we always give it a try. Methotrexate, I'm not sure. I haven't had much experience using methotrexate in preference to these. Then we come to the monoclonal antibodies, and that's a tricky situation as well, which is infliximab. How much does infliximab help? In my experience, not much. Somebody here may contradict me, and perhaps they've had wonderful experience. Mine is not that great. Adalimumab is another one of the monoclonal antibodies. It's basically an anti-TNF. It's usually given at home in the United States, and so it's very user-friendly. Rituximab might be more useful if you thought there was a great deal of B-cell infiltrates or nodular hyperplasia. Other than that, I'm not sure how well it would be useful. The new kid on the block is vedolizumab, which is an anti-integrin antibody. It prevents T cells from migrating to the GI tract, and that is the most probably specific therapy that we can think about right now. There hasn't been very much out on that yet. We few times. I'm hopeful that it might supply some useful therapy, but I think the jury is out on that. It would theoretically make the most sense, but we can't be sure about that. Natalizumab perhaps is a little bit too potent for us because it keeps T cells from going anywhere that you really want them to go, including the brain, and I've been myself a little bit hesitant to use that. Fusion proteins, perhaps etanercept, which would be an anti-TNF, and then JAK inhibitors. JAK inhibitors are licensed in the United States for ulcerative colitis, and I've seen one patient on a JAK inhibitor who told me he was just fantastic on it, but again, the jury is out. So we are borrowing therapies continuously. The GI tract is a complicated place. Do we really want to keep those Tregs out of the GI tract? That's the problem with the vedolizumab. It will tell all T cells to stay out. Is that a good idea? I think the jury is out. We have all these bacteria up here. We have no IgA because most patients with IgA deficiency, most people with CVID don't have any IgA. But you have a great number of bacteria here that we haven't coped with. And just two other tiny slides. I know we're running just a little short, so I'm going to wrap it up. What do we know about the microbiome? I brought that up a moment ago, and I think that we have substantial ignorance about this area, and we will probably get a lot better. My own lab, and I'm interested in the role of the innate lymphoid cells in inflammatory disease because I think that they have been underappreciated, and of course genetic defects. The reason why I'm interested in the innate lymphoid cells is that we find populations of cells in the blood of patients who have CVID that do not belong, and they are inflammatory in nature, and they are in this category of a sort of a new population that are not really lineage positive. They're not T and they're not B, they're not dendritic, but what are they? And so we've done some work on those. They contain sort of an inflammatory potential that's kind of interesting. But I wouldn't be that interested in them unless I could see them in the GI tract. And so these are gamma interferon secreting cells that are not T cells because otherwise they would have double stained as this. And so they're present in the GI tract, and I don't know what they are. I can't individually isolate them, but I can say that they don't belong and they aren't T cells. And so what are the nature of these cells? And other markers don't display that either. They can be ROR gamma T positive, however, which is an interesting additional marker that they may bear and indicates they are a new set of inflammatory cells. Just two words about genes, and I think this is it, which is that under what circumstance when you have a patient with very, very severe enteropathy, they look like they have CVID, they are 5 or 10 or 15 or 20 years old and they're really doing very badly and it's a lifetime situation, under what circumstance will you be getting whole exome sequencing and other studies on those patients? And these are the ones that we've been concentrating on. I have a project with Jean-Laurent Casanova and Bertrand Basson at Rockefeller, and these are the patients that we've concentrated on. The patients with very low or absent B cells, more than one member in a family, severe inflammatory autoimmune disease, and very early age onset. And you can get some genes out when you cherry pick what we call CVID for monogenic disease. Of course, like everything else, it's not going to always be so simple because the CTLA4 can be present in other family members as well as STAT3. Other family members may or may not have the same phenotype. And so again, it's a little bit more like CVID always is, which is C for complex, not C for common. That's my motto. And I've just had a lot of people who helped me at Mount Sinai and Rockefeller, Baylor Institute of Immunology Research, and then my colleagues at Yale University. So thank you very much.